Compliance in the medical records. Compliance is an effort to reduce fraud in a medical organization, to reduce coding, billing, and reimbursement errors, and improve quality and stand in the medical facility. 5 federal and abuse laws applies to physician. The False Claim Act or the FCA, Civil Monetary Penalties Law, the Anti-Kickback Statute or the AKS, the Physician Self-Referral Law or the Stark Law or Exclusion Statute. Enforcement of these laws is the responsibility of the Department of Justice, the Office of the Inspector General, the U.S. Department of Health and Human Services, and CMS. Fraud and abuse. Fraud is the intentional deception or misrepresentation that an individual knows to be false and makes it knowingly that can result in unauthorized benefits. Some examples of fraud are billing for services not providing, altering claim forms to obtain higher reimbursement, soliciting or receiving kickback or bribe, upcoding to receive higher reimbursement. Abuse happens when a healthcare entity do not follow proper coding and billing guidelines. Some examples of abuse are submitting excessive charges for services, violating Medicare participation agreement, billing Medicare at a higher and different fee schedule, and making place of code errors. Federal and abuse laws. The Federal False Claim Act. Any person who knowingly uses a false record or statement to get a fraudulent claim paid by the government. Civil monetary penalty laws. Penalties may be imposed for various forms of fraud and abuse involving the Medicare and Medicaid programs. The Anti-Kickback Statute prohibits a reward or inducement for patient referrals to generate business involving any item covered under Medicare and Medicaid. Physician Self-Referral Law, referred to as the Stark Law. It limits physicians' referral to entities with which a physician has a financial relationship. The Exclusion Statute. OIG is required to exclude individuals and entities from participating in all federal healthcare programs for those convicted of Medicare and Medicaid fraud, patient abuse or neglect, healthcare fraud-related theft or financial misconduct, manufacturing, distributing, prescribing, or unlawfully dispensing controlled substances. The federal government, especially the OIG, has a zero-tolerance policy towards fraud and abuse. Compliant plans offer the provider an opportunity to participate in a nationwide effort to reduce fraud and abuse in our national healthcare programs. Coding, billing, and reimbursement errors can be significantly reduced by implementing a compliance plan. OIG developed a work plan for physician practices that includes recommended elements of a compliance plan. The plan is available on the internet and the website is at the bottom of the slide. Continuous monitoring. In addition to education and training programs, policies, a successful compliance program should also require thorough monitoring and implementing regular reporting to senior executives and board of directors. Attention should be paid to the following areas: CPT, HCPCS, and ICD-10 CM coding issues, pricing, chart sheets, report and record keeping, contracts, competitive pricing, OSHA requirements, and CLIA. Selecting CPT, HCPCS, and diagnosis code. Choose a code that most accurately describes the service performed, test ordered, or supplies furnished. The hospital charge descriptive master or the hospital charge master is at the heart of the healthcare revenue cycle, serving as a hospital's starting point for billing patients and payers. A hospital charge master is a list of all billable services and items to a patient or a patient's health insurance provider. The OIG views intentional upcoding, that is selecting a code to maximize reimbursement as raising false claim issues. Submit only the diagnosis code that accurately describes the patient condition, reason for tests ordered, surgery performed, and or supplies. And I do have a picture of what the charge master looks like. It includes the department, the charge code, the charge description, the price, the revenue code associated with that CPT code, modifier if any is there, and the CPT4 code. National Corrective Coding Initiative. CMS developed the NCCI to promote national correct coding methodologies and to control improper coding that leads to improper payments in Medicare B claim. The purpose of the NCCI is to prevent the reporting of two separate codes when a third separate code represents a combination of services. It requires healthcare provider to report complete procedure codes rather than parts of the complete procedure. And it also requires healthcare providers to report only the most extensive version of procedure performed, disallowing reporting of both limited and extensive procedure. The NCCI Policy Manual for Medicare states procedures should be reported with the code that most comprehensively describes the service performed. Unbundling occurs when multiple procedure codes are billed for a group of procedures that are covered by a single comprehensive code. NCCI file contains code pairs called Column 1 and Column 2 that edits payment for services where two codes should not be reported together. When Column 1 and Column 2 codes are billed together, carriers who follow the NCCI edits would only pay for the Column 1 code and not the Column 2 code. And there I have an example below that shows you Column 1 and Column 2 code. Medically unlikely edits. Medically unlikely edits place maximums on the number of units of service per CPT code that can be reported by a provider for the same patient on the same date of service. Not all CPT codes are assigned an MUE. Most of the CPT codes with an MUE are published by Medicare, who updates the table quarterly. MUEs are assigned for a variety of reasons, such as policy or statutory restriction, clinical benchmark. Units of service in an excess of an MUE are denied.